Good morning, everyone. I'd like to welcome you to the Sickle UHN Building Community Patients and Families Living with Sickle Cell Disease and Emergency Department Care Provider session. My name is Lanre Tunji Ajayi, the CEO and President of the Sickle Cell Awareness Group of Ontario. Before we start this morning, we would like to acknowledge the land on which we are doing this session. We're grateful for the opportunity to gather, though virtually, on this land, and we thank the generations of Indigenous people who have taken care of this land long before other nation groups came. In particular, we acknowledge the traditional territories of the Ojibwe, the Anishinaabe, and the Mississaugas of the New Credit, whose territory is covered by the Upper Canada Treaties. We also recognize the contributions of the Métis, Inuit, First Nations, and other Indigenous peoples have made in shaping and strengthening this province and this country as a whole. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the present and the future. I encourage everyone at this session to actively seek information and take action. Thank you. Recent studies show that 55% of individuals living with sickle cell disease in Canada reside in Ontario. Sickle cell disease patients are at high risk for life-threatening infections, strokes, and many complications related to vessel occlusion. It is crucial that healthcare providers in all emergency departments and inpatient units across Ontario be equipped with the knowledge of care required for sickle cell disease. Research has also shown that prompt attention, recognizing the urgency of care needed to avoid worsening clinical condition, will result in fewer life-threatening complications. As such, it is important that patients, their caregivers, and the care providers continue to have dialogue opportunities that will improve the care they receive. So this morning, we're pleased to have patient experts sharing on their experience with the care providers at the University Health Network. We're also very grateful that the University Health Network Emergency Department Sickle Cell Working Group have partnered with Sickle to bring about this very important discussion. Without taking much more of your time, I'd like to introduce the individuals that we have as panelists today. But before I do that, there are a few housekeeping rules that I'd like to share with everyone. At the bottom of your screen, we have the chat box. Folks at home, everyone, kindly use the chat box to put your questions and comments. We will be looking at the chat box and will be responding accordingly. If you prefer to raise your hand, you can also do that. I will also advise everyone to kindly mute your audio to ensure that there are no noise interference. And on this note, I will do a brief introduction of everyone. We have Ms. Fitz-Ann Marie Howell. Ms. Fitz-Ann is the co-owner and operator of Divine Beauty Oasis, a mobile spa located in the Greater Toronto area. She's also a licensed medical esthetician and makeup artist that is currently in school, also studying massage therapy at Humber College. Living with sickle cell disease has taught Ms. Fitz-Ann a lot about herself, including the resilience and strength that individuals with sickle cell disease possess. She has risen to every challenge that she faced. Welcome, Ms. Fitz-Ann, to this session. Another presenter we have today is Mr. Gabriel Badejo, who is an Afro-Canadian producer and director based in Toronto. From a young age, Gabriel had a passion for storytelling. But growing up in a Nigerian household, he was pushed towards the traditional stability of the big three: a doctor, a lawyer, or an engineer. Gabriel reluctantly pursued an education in electrical engineering with the hope of following his passion for filmmaking on the side. His profound realization that he could not imagine living the rest of his life without giving his passion for filmmaking an honest commitment encouraged him to forgo everything he was building towards. He enrolled at the Toronto Film School and began his journey as a professional storyteller. Soon after enrolling, Gabriel secured a production assistant role on a renowned television series called The Next Star. Having proved himself within the industry, Gabriel went from production assistant to director and production manager to producer soon after. Gabriel has worked with artists such as Jesse Reyes, Billie Eilish, Sunreal, and Popcorn, brands such as Google, Converse, Moose Knuckles, and Jameson Whiskey, and Canadian Screen Award-nominated show CBC Germs The 410. Mr. Gabriel will be sharing his story and his experiences around sickle cell disease today. We also have Ms. Serena Thompson. Ms. Serena Thompson was born in New York to West Indian parents who never heard of sickle cell anemia. Serena struggled physically and emotionally through life in her early years while living in Toronto. After experiencing 30 years of humiliation, misunderstanding, isolation in schools and hospitals, and other places of employment, Serena became engaged in the sickle cell community as an advocate by joining the Sickle Cell Association of Ontario in 2009 and was voted on as a board member and social support committee chairperson for 7 years until the end of 2016. She has now become the vice president and director of programs of the Sickle Cell Association of Ontario's 2019 new board. Serena recently served as a member of the Minister's Patient and Family Advisory Council. She's serving on the Healthy Debate Committee, Medical Directors Admissions Committee, Patient Alliance for Patient Safety, Taibu Adult Sickle Cell Support Group, Steering Committee, Chair of UGMR Sickle Cell Fund, and is the Outreach and Community Engagement Officer for the Youth in the Year Program and Coalition Board. Welcome, Ms. Serena Thompson, to this session as she shares her sickle cell experience. We also have with us today from the Sickle Cell Working Group of the University Health Network, Dr. Jennifer Bryan, who has been working very closely with myself in putting this together. Dr. Bryan is an emergency physician at the University Health Network in Toronto. She is a director of operations of the Toronto Addis Ababa Academic Collaboration in Emergency Medicine and an assistant professor in the Division of Emergency Medicine at the University of Toronto. She's a founding member of the UHN Emergency Department Sickle Cell Working Group and is the lead of the upcoming CAEP 2021 panel on anti-racism and anti-colonialism in emergency medicine. Welcome, Dr. Brian. We also have on a panel and presentation today, Ms. Ruth Appiah Boateng, who is a registered nurse. She's what I would call emergency department nurse. She started her career after completing a BSc nursing at the University of Western Ontario. Before accepting a role in the emergency department at Toronto General Hospital, Appiah Boateng worked in rural and indigenous communities in Northern Ontario. As a certified emergency nurse, she's worked in community hospitals and is also certified in critical care. Ruth believes that education is the path forward to help nurses have all the tools necessary to provide effective, socially informed, patient-centered care. Welcome, Ms. Appiah Boateng. From the Sickle Cell Working Group of the UHN, we also have Dr. Hassan Sheikh. He is an emergency and addictions physician in Toronto at the UHN. He's a lecturer at the University of Toronto Department of Family and Community Medicine. He's a member of the UHN Emergency Department, Sickle Cell Working Group. Dr. Sheikh will be helping with a lot of the technical stuff surrounding this session today. So he's the one that is ensuring that we don't have any technical glitches. He's not only a doctor, but he's also very techie savvy. So thank you and welcome, Dr. Sheikh. Lastly, but not the least, we have a member of the Hemoglobinopathies Clinic, the red blood cell disorder of the UHA. Dr. Jacob Pendergrast is whom I have worked with over many years. He is a clinical hematologist and has been treating patients with hemoglobinopathies in the Toronto General Hospital's red blood cell disorder since 2004. Dr. Pendergrast is a founding member of the Quest Research Collaborative, which focuses on issues of quality, utilization, education, and safety in transfusion practice. His own research interests have centered on education in serology and adverse transfusion reactions, particularly IVIG-associated hemolysis and transfusion-associated circulatory overload. He has served as a reviewer for the journals Transfusion, BMI Quality and Safety, and Transfusion Medicine Reviews, and at the latter has recently taken on the new editorial position of social media consultant. He currently serves as the chair of the Medical Advisory Committee of the Sickle Cell Disease Association of Canada. Welcome, Dr. Jacob Pendergrast. Without taking much more of your time, we will go to our presentations, our presenters today. And I see we have about 45 people have joined us. We have about 81 people that are registered for this session, so I know more people will be joining us. And I just also want to mention that the Sickle Cell Awareness Group of Ontario has recently formed a council that we call the Patient Advisory and Advocacy Council. This is the body that will sit on different working groups in hospitals and bring the patient voices, to be heard in the right places. So this session actually is put together from this council, from SCD, in collaboration with the UHN Sickle Cell Working Group. Thank you, everyone. So without taking much more of your time, we need to go into the presentations, and our first presenters are Mr. Gabriel and Ms. Fitz-Ann. Sorry, give me 1 second. Can everyone see my screen?
Yes.
So Fitz-Ann and Gabriel, would like you to take on the presentation from here. Thank you.
So my name is Fitz-Ann. I'm an esthetician and a makeup artist. I'm currently in school for massage therapy, as Lanre previously said, and I am the co-owner and operator of Divine Beauty Oasis Mobile Spa.
Hey everybody, I'm Gabriel, Badejo, and just wanted to thank everybody for being here for something that I feel is very important to me and for many Canadians and people living with sickle cell globally. So thank you. And yeah, as Lauren mentioned, I'm a film producer. I've been working in film for like about 8 years-ish, and yeah, been had the pleasure and been fortunate to work on many great projects that I'm very proud of. And yeah, let's get into it. So many people, if you don't know what sickle cell anemia is, sickle cell anemia is a inherited red blood cell disease. And it pretty much, long story short, it pretty much prevents the red blood cells from carrying oxygen to wherever it needs to go, arteries, organs, everything. It's a lifelong chronic disease, causing life-threatening complications, multi-organ failure, strokes, premature death, the list goes on. Pretty much our red blood cells are very essential for our human function. And if that is impeded or affected, you can kind of have a picture of how this illness can affect every part of the body. So yeah.
So sickle cell and living in Ontario, many cases, many individuals may not have access to comprehensive care. So this includes drugs, proper treatment, knowledgeable providers. We may also be stigmatized. So a lot of the time we're called drug addicts and we're just drug seekers, which is not always the case. It's not true. Our quality of life is a lot lower than those who don't have sickle cell, especially living in Ontario. Our life expectancy is also lowered by about 25 to 30 years, depending. And based on our standard of care is usually subpar. So that can also cause a lot of complications that could have been prevented and even premature death. So I've been a patient at TGH, Toronto General Hospital, since about 2013. I've had various experiences there, most good, not all of them great. In the last 5 years, I've visited the ER department at least 15 times. And those timelines range from a few hours to days. The wait times generally from entering the ER department to seeing a doctor can range from minimum an hour to maybe 2.5, sometimes 3 hours. My best experience was actually this year, February. I had an ER nurse who was on top of everything. She contacted the doctor before I even got settled. She got my meds on time. She was on top of everything. And even though we were in the middle of a pandemic and COVID was going around, she did not make it seem as though I was just a bother or an issue to her. She made sure that I felt comfortable, I was welcomed, and I really appreciated that. I felt like a person. For my worst experiences, I've had two. In 2015, I went into the ER and complaining of chest pain, and I was unable to breathe. They took x-rays, took blood, they found nothing. And all I'm telling them, I still cannot breathe. They said there's nothing else they could do for me. My mom is telling them I cannot breathe. They send me home. And for them not listening to me and taking my case seriously, it caused me to have to go back the next day after being discharged from the ER. And it turned out I was breathing with half a lung, and it caused me to be there for 4 weeks when I could have been there for maybe like 2. My second worst experience, I had a nurse. She was an older nurse, and I don't know if it was her experiences or because she felt she knew more than everyone else. She kind of had an attitude. She was trying to administer an IV. She poked me about 13, 14 times. And in that time, she was trying to start an IV and draw blood. And with all those pokes, she was unable to get like anything. She wasn't able to get anything. No blood, no IV started. My veins are small. Our veins are normally smaller and it's more difficult, but even though me and my mother were asking her to get another nurse, call someone else, she gave us an attitude as if we were downplaying her experience and her knowledge. And after that, we had to get a student nurse, or she had recently graduated from school, and within 5 minutes, she was able to get blood, start an IV, and administer pain meds.
Okay, so I've been seen at TGH since 2010. I've only been to the ER for about 4 or 5 times for reasons you'll hear in a little bit. But my best ER experience at UHN, which is typically just Toronto General, because that's the only hospital I've been to in the emergency department in the UHN. So best experience was actually last year. I was actually on the way downtown to the day party of the year, and on my way down, I felt a pain crisis in my knee. By the time I got downtown, was feeling that the pain got a lot worse where I wasn't able to stand. And so my friends drove me to the ER. As soon as I got there, I let them know I was having a sickle cell crisis, and like almost immediately, which I feel like is rare, I was given a bed and given pain meds and treatment. And it seemed like all the staff, the doctors and nurses were knowledgeable of sickle cell disease, and just made me feel welcomed and didn't make me feel like I was putting on an act or anything. Like they were listening to me and what I was feeling, and within a day or two, I was good to go out of the hospital and on my way. My worst ER experience at Toronto General, it's a bit out of the 5-year mark. I know we want to keep it within the 3 to 5 years, but I felt like it was kind of important to note, just based off of like how things are normally done at hospitals in my experience and other people's experience with sickle cell. Also, I should note that most situations, experiences or visits to the ER for sickle cell patients are bad experiences. We're usually not heard. So I just want to preface that, like, it's not like there's some bad and some good. It's mostly all bad. And the good ones are just like the nurses and staff doing what we feel what the treatment is in a good time. And yeah, but in about like 2013 or 14, I went to the ER with a like terrible, like probably one of my worst crisis in like the last 10 years, and had a chest crisis and a lower back crisis. And when I got to the ER, I was in so much pain that I couldn't even reach the triage, and I couldn't sit down because it was too painful to sit in that position, and I couldn't stand because I was in so much pain. So I ended up just lying on the emergency room waiting room, and I was there like screaming and crying in pain for about like 15 to 20 minutes. A nurse then came over to me and asked what was going on. I told her I had sickle cell. She asked for my health card, gave it to her, but it was kind of a struggle because I was in a lot of pain. She then asked me to sit down in a chair, and I told her I can't because I'm in so much pain. And she then insisted that I sit because I can't. They don't want me on the floor. But like from then, I couldn't even respond to that because like clearly, um, if I was good, I would be sitting in the chair. I don't want to be crying in front of a bunch of strangers on a waiting room floor. So fast forward, I then later on got like pain meds and treatment, and I was kind of in and out due to the pain meds. And later that same night, I came to, and my mom was wheeling me out of on a wheelchair. And I asked her what was going on, and she said, "Oh, you got discharged." And then I just like paused, and I was like, "But I can't walk." So, like they discharged me when I was in so much pain that I still couldn't walk, and I pretty much went from that hospital and on the way home, like the pain was so bad that my mom just drove me to another hospital, and I was at that hospital for about a week and a bit. So since that experience, I like did everything to avoid going to TGH because I felt like if they could treat me like that, then this is not the place for me. So it kind of took me some time to go back there. Okay, so admission experiences. Yeah, my the same experience that I experienced last year, where I was in the hospital and I was admitted for like a day. That was great. Everybody was on the same page. It was phenomenal. I was out quick. And I should also mention, like, the quicker that we get treatment, the shorter our stay in the hospital usually is. So yeah, all was great. I was out in a couple of days, living my life. My worst experience in admission at TGH was actually just a month ago in the beginning of October, where I went in with, again, a bad crisis, chest crisis, chest pain, lower back pain, hip pain, and shoulder pain because I also developed AVN, avascular necrosis because of sickle cell. So pretty much everything was hurting. I was in a lot of pain. Got to the ER. Within about an hour, I was given a bed and pain meds, but a small dose, about 1 milligram of hydromorph, which I have at home. So it's getting 1 milligram of hydromorph isn't really anything crazy for me, but like for me personally, I'm actually also a very deep sleeper. So when I do fall asleep, it's hard to wake me up. So I ended up falling asleep, and the nurse came to try and wake me up, and I guess he couldn't. So he hit me with, he gave me Narcan to reverse the pain meds because he thought I overdosed. And I asked him, I woke up, not because of the Narcan, but I woke up in a ton of pain. So I asked him what happened. He said I overdosed, and I told him I didn't. And then it's kind of like his word versus my word or whatever. But because of that, they stopped giving me pain meds. So when I was admitted, because of what happened in the ER, they were scared to give me pain meds. So they would give me like maybe 1 milligram of hydromorph every 4 or 5 hours. So when I get those pain meds, I'd get maybe half an hour to 45 minutes of relief. And then I'm back at level 10 for the rest of the time until I get my pain meds. And that went on for about 4 days where I was it was kind of like a tussle with the doctors on how I felt I should be treated versus how they were, the treatment that they were giving me. And it was very hard to explain it because they just weren't listening. And once they kind of label you as like you overdose and they think that you are a drug abuser or some of the sort, they treat you less than, and no one really wants, the nurses don't really care to you as they should. And yeah, it was kind of a terrible experience going back and forth and being in pain for so long.
So my best admission experience just happened to be a nurse who's also a family friend. I had to ask for nothing again. She had the best attitude. She was attentive. She made sure that I got my medicine even maybe 5 minutes before with the time. Like, she was on top of things. And most people would say she's biased towards me, but she also had the patient in the bed next to me, and she treated them the exact same way. She took me on walks, and on the walk, she would attend to other patients, and just like that, she would treat them exactly as she treated me. And just her attitude, her energy, knowing that someone cares for you in a situation like that, where you can't care for yourself, you can't do much for yourself, makes the experience that much better. My worst admission experience happens to be related to my worst ER experience. So after that time I was admitted, I went in with a acute chest crisis. So at the time I was breathing with half a lung, and they had tubes in my neck, tubes in my throat, tubes everywhere. After about a week or two, they said the fluid that was in my lungs had cleared up, but I had another infection. They said that it's all of the tubes that are in my body are causing me these infections. And even though I was saying, no, I think you should check something else, I think you should try something else and see what else could be causing the infection, they fought me. They fought me so hard and said, no, it's all of the tubes. So mind you, I had an IV in my neck. I had a breathing tube in. I had pain medicine tube in my neck, all of those. And to go from no pain, like you're finally getting to a comfortable place where the pain is calming down, to then take all these tubes out, which are keeping you afloat, to then have to put them back in because they found out that those tubes are not causing my infection, just kind of added more time to my stay. So whereas I could have been in there for maybe another week, maybe a week and a half, I was there for another 2.5 weeks because they wouldn't listen to me and what I felt like was going on in my body. So I feel like the on-call doctors or the on-call nurses on whatever floor it may be, sometimes they don't take in what you're trying to tell them, especially because you know your body. No one knows your body better than you. So I think they just did what they wanted to do, and at the end they had to put all of the tubes back in and caused me to be in the hospital for a lot longer than I had hoped.
Okay, so on a different note, trying to strategize ways to make things better for sickle cell patients when they get to the hospital. So we feel that UHN needs a standardized protocol for triaging and for the triage, emergency department, and through their admission stay. This protocol shouldn't be or try its best not to be subjective to personal interpretations, because not everybody will know or be an expert in sickle cell. Obviously, like there's many other illnesses and things that people need to be aware of, but this protocol should be very easy for someone who doesn't have that type of knowledge to just read and understand quickly and know how to treat patients with sickle cell.
So with this standardized protocol, they should be consulting the patients, the sickle cell patients, and they should also have close ties with the Patient Advisory and Advocacy Council and with SCAGO, so that they're making sure that they're staying on top of things, doing what we need them to do, and not just, again, keeping it subjective for their interpretation.
Also to keep up with the protocol, because not everything is perfect in the beginning, having a monthly check-in with staff, physicians, and SCAGO who represent patients. Check-ins on how to make this protocol better and make sure it's being upheld and good for everybody.
With that, they also need to continuously review it and make sure that it's up to date, making sure that the protocol is operating at its best optimal levels, because things change, times change, people change, and your patients are going to change, right? So you're going to need to make sure that it fits every single sickle cell patient that you see.
And then, Fitz-Ann, want to take that next point?
Sure. So the focus on respect and empathy is a big thing for us as well. So most of us have had sickle cell forever, and we know what's best for us. So to give us the credit when we're speaking on what we need, what we're going through, and everyone's situation is different. Everyone's experiences are different. So we need to look into those experiences as well and understand that although we are going through the same thing, each one of us are different, and we know what we can speak on.
Also, it's very important to note for doctors and nurses that come into contact with participants, the pain that we feel is like immense, like nothing that I can even compare it to. So when we come in with a pain crisis and we're, in pain, and we're telling you that we're in pain, and we're saying our pain level is level 10 or whatever, like, please take our word for it. And because we've been living with this pain and discomfort our entire lives. And so with that comes us being able to find ways to help manage the pain and deal with it ourselves. So even if we don't look like we're in a ton of pain, it's just we've had so much experience dealing with the pain, we just don't react to it as if it's the first time it's happened to us. We know how to kind of do what we need to do mentally to help prepare for it. So if it looks like we're not in that much pain, and if it looks like we're in not that much discomfort in your eyes, that's often not the case. If we are telling you that we're in a lot of pain and discomfort, we almost 100% of the time are in that much pain and discomfort. So please listen to our voices and be kind and empathetic to our situation.
And lastly, overcrowding. The various times that I've been to the emergency department, it has always been overcrowded. And more than once, I've been sent to the rapid checkout section. And in my eyes, if that overcrowding could kind of be dealt with and the nurses weren't so overwhelmed, I feel, then they could deal with all of the patients depending, it doesn't matter the number of patients they have, they could then deal with them in a different light. And it wouldn't be more of, let's hurry up and get this person who doesn't look like they're in a lot of pain quickly out of our way so we can deal with something worse kind of thing. And I feel like most of the time that's how we're treated, because we don't look like it. As Gabriel said, we don't show our pain all the time. So we get pushed through as if we're not that important. But if it wasn't so overcrowded, if there was a way to tailor that and kind of work on the overcrowding issue, we'd probably get better care in the emergency department and more than likely not have to be admitted or spend days in the ER.
Thank you everyone for hearing us out and listening to our voices and stories. I'll hand it over to the doctors to present. Thank you.
Thank you.
Well, that's amazing. I learned a lot from your presentation, Gabriel and Fitz-Ann, and I'm sure the UHN team are listening to you, they are hearing you. In my mind, in my opinion, from what Gabriel and Fitz-Ann presented, it sometimes also depends on who they encounter. Some of the care providers, they had good experience with them because they know what they're doing, and some not so good experience because of limited knowledge around sickle cell disease, I will presume. So we have the Sickle Cell Working Group, the Emergency Department Sickle Cell Working Group of the University Health Network, with Dr. Jennifer Bryan and Ms. Ruth Happier, who are working very hard to improve the experiences of our patients at UHN. So we're going to hand over to them to present to us on what the working group is doing. Dr. Jennifer Bryan.
Thank you so much, Lanre, and thank you so much, Gabriel and Fitz-Ann. I'm going to let Ruth get started here. So Ruth, you go ahead.
Okay. Hi, everyone. Thank you for joining us today. Thank you, Gabriel and Fitz-Ann, for sharing your experiences with us. I know it must have been really hard. We're very grateful for you to be transparent with us. My name is Ruth, and I work at Toronto General in the emergency department. Although I do not live with sickle cell, I am passionate about it and helping and bring improvements to the emergency department. And so because of that, I'm working alongside Dr. Bryan to present this presentation to you about what we can do from the healthcare providers to help build a proper community, solid foundation with our sickle cell community.
Thank you, Ruth. And just like Ruth mentioned, our working group, so our emergency department sickle cell working group, was formed in response to stories like those shared by Fitz-Ann and Gabriel. And so we've seen that, that the care in the emergency departments across the province isn't what it could be for sickle cell patients. And so that's why we're working to try to make things better. So especially special thank you to Lanre and Skago for helping us to host this forum today. Ruth and I are going to be speaking both to the healthcare workers who are joining us, so welcome all of you team members from UHN, as well as to our patients and family members today.
So to build a solid community, it involves shared attitudes, interests, and goals, and everybody wants to feel respected. Everybody wants to receive good quality care, and everybody wants to be pain-free. So the same should go to those dealing with sickle cell crisis.
Absolutely. And like Gabriel and Fitz-Ann spoke about, one of the biggest barriers that we hear about from patients is facing facing stigma and facing racism in the hospital, in the emergency department. Serena Thompson, who's joining us today as a panelist and was introduced at the beginning, described in the Canadian Medical Association Journal earlier this year the challenges of being labeled by her illness and facing negative stereotypes when seeking care. This very much echoes what Fitz-Ann and Gabriel spoke about, and this article was a real touchstone in emergency medicine and led to a lot of important conversations. One of the ways that stigma shows up is very much, again, in what Gabriel and Fitz-Ann spoke about, in being labeled as drug seeking or opioid dependent. And so it's interesting to compare how common we think opioid abuse is in our patients with sickle cell compared to how common it actually is. There was a study done out of the States looking at perceptions of emergency care providers of patients with sickle cell. And most of the care providers thought that opioid use disorder was fairly common in patients with sickle cell, and thought maybe up to a fifth of patients were using opioids for reasons other than managing their pain. But in reality, what we know is that that number is vanishingly small. So less than 2% of patients with sickle cell have issues with opioid use disorder. So this is a very rare situation, and doesn't need to cloud how we manage pain for patients with sickle cell in the emergency department.
What can we do as healthcare providers? One, we need to remember that pain is subjective. We don't know what those dealing with sickle cell crisis are actually going through. So being non-judgmental and being empathetic. We also need to know that because that they're having a sickle cell crisis, their pain tolerance may be higher that we may not be used to. So understanding that they may be getting higher doses that we're not used to giving. Sometimes we're used to giving 1 to 2 milligrams. The other day I was giving Dilaudid 6 milligrams IV to a patient dealing with sickle cell crisis. So we need to respect them and believe them instead of saying, well, they don't look this way because they're not showing the pain that we think that they should be showing. The next thing we need to really include is shared treatment plan. Everybody wants autonomy over their own health. So why is it that once they come to the emergency department, we take all that power from them? It's so important that we include them in the planning and the goals. When we tell our patients and include them in their care, they are able to even tell you when to titrate the medications down, or when, you know what, the pain medication is sufficient enough. So we need to make sure that even when they're getting discharged, they're taking independence again over their own care. So we need to make sure that we include them in the treatment planning and even when we change the orders. The next thing is support coping mechanisms. We also need to recognize the coping mechanisms that those dealing with the sickle cell crisis experience. And that includes listening to music. Sometimes they're sleeping, walking, pacing, eating, sleeping, and at times praying. So it's so important to recognize that these are coping mechanisms to help them with their pain, instead of judging them and saying that, oh, they're not in pain because they're on their phone. So as healthcare providers, we also need to remember to ask them as well. Like, I noticed you're on your phone. Is that helping you with your pain right now? Is the pain medication not efficient enough? The other thing is we need to teach our peers who may lack knowledge. It's so important this is a teachable moment for us all. If we know something more than our peers, it is not a sign of weakness, but it's an opportunity to share the knowledge that we have. And when we share the knowledge that we have, we're able to help and maintain a consistent care for those dealing with the sickle cell crisis. The last thing that is so important is advocating for those who can't. People come to the emergency department not at their best. And as Gabriel and Fitz-Ann explained, there are times that they can't even walk or talk. So this is a time that we can actually be able to step up to the plate, be able to initiate pain medication right away, get the doctors or any other specialists involved in a timely manner that we're able to provide the care for them, because this is the time that they're most vulnerable at. Why don't we make sure that we provide the care that they need by being the voice that they can't be? So present and future, I can tell you right now, change is coming. We are creating change from the first encounter within the emergency department, and that starts with triage. We're ensuring that we are not judgmental, that we are empathetic, and that we triage you and get you into a bed in a timely manner. Order sets, as Fitz-Ann and Gabriel mentioned, we are working with order sets. Order sets is a way where we standardize care with sickle cell crisis. It's a shared effort between hematology, the emergency physicians, and input from our partners, patient partners. And this is where we're able to provide guidelines on how patients need to be started, what blood work needs to be initiated. We're also working on a goal to time to analgesia within 30 minutes. That's actually the gold standard based on the US papers. The next thing is the Emergency Sickle Cell Working Group, which includes myself, Dr. Brian, Serena from the Sickle Cell Association of Ontario, and Skago from Lanry. We're all, and my other additional colleagues, Dr. Sheikh, Dr. Hume, Dr. Sine, Nia, I'm not naming everybody. If I forgot you, sorry. But we're working together to create improvements in the emergency department. And it's not just right now, it is going to be consistent so that we continue to provide the best care that we can. Education. We know that education is lacking on sickle cell, even in the materials in nursing school and in med schools. And because of that, we're actually partnering with our clinical educators in the emergency department to include sickle cell in the orientation and in the yearly education days to talk about sickle cell, how to treat sickle cell crisis, and the complications that it comes with. And last but not least, we cannot be for you without you guys. And that's why we're working in partnership with you guys. It's important to hear your stories so that we can do better, and also make sure that there's consistency across for your care. And hopefully the next time you guys come, it will not be a negative experience, but a positive one.
Exactly. So what we want is we want those good, reassuring experiences in the emergency department and in the hospital to be the norm, not to be the exception. Right? Part of the way that we want to move forward is by increasing the feedback that we're getting from patients and families that are living with sickle cell. So this is a big ask of you, but we're hopeful that you're willing to come and work with us. In order for us to improve, we need to hear about the things that are working well and the things that aren't working well. We've heard that people are reluctant to report concerns to patient relations, fearing reprisal or feeling that those concerns don't go anywhere. But we really want you to reconsider and involve patient relations, both when things haven't gone well and when they have. This is a chance for you to really directly impact your care at UHN. Our team is eager to do things better, but we do need your help to guide us. I know that on the call today, we have Jane Ballantyne from Patient Relations, who has been working with Lanray and Skago recently at the General Department's meeting, focusing on sickle cell just in the last couple of weeks. And so in our discussion a little later on, hopefully we'll have a chance to bring in some of our other UHN colleagues who are on the line as well.
And we're going to end it with the famous words of Maya Angelou: what you did then, what you knew how to do. When you knew better, you did better. So when you know better, you do better. And today, hopefully, this provides more of an insight to healthcare providers on how we can properly care for our community dealing with sickle cell. And this is also holding each other accountable so that by the time, hopefully, if you have to come to the emergency department, it isn't a negative experience, but a positive one, and you guys do see some changes and improvements. Thank you so much for your time and for sharing your experience with us.
Wow.
Thank you, everybody.
Thank you so much, Dr. Jennifer Bryan and Ms. Ruth Harpier. But that was excellent. The future is brighter at UHN, I can tell you. As Dr. Bryan mentioned, we had a meeting just a few weeks ago based on the research study that Skago did, and again, the narratives from the patients that have been at the hospital. And even by the sheer number of participants on that meeting call with myself from UHN, it gave me a lot of hope, and I was very pleased to say to you that UHN is looking to make improvements and to ensure that the care is optimal for every individual that comes into this hospital. And it's very good. For me, I think for sickle cell patients, the focus should be comprehensive care. Every sickle cell patient should be seen by a specialist, and emergency should be very minimal. If you're seen in a comprehensive sickle cell disease center, you'll be able to have access to that kind of treatment that is optimal for sickle cell patient. But we do know that things do happen that also require emergency, and when those happen, we want to make sure that our patient got the best care that they could get. As Fitz-Ann said, empathy and respect is very, very important. Research has shown us that when you're kind to somebody in pain, it even brings down the perception of their pain level. So it's very important that we show that empathy. And I know the Sickle Cell Working Group at the ED of our very big hospital, UHN, is working to improve on our experiences. Thank you. On this note, we will go to our panelists. You have heard from Ms. Ruth Hapier, from Dr. Jennifer Bryan. You've heard from Mr. Gabriel Badejo and Ms. Fitz-Ann, but you've not heard from Dr. Jacob Pendergrast and Ms. Serena Thompson. We will bring these two individuals to join the four presenters, and you'll be able to ask them questions. So, attendees, I would like you to start putting your questions, your comments in the chat box so that we can start to get our panelists to respond to your questions and your concerns and your comments. However, while you're doing that, I'd like to start off with Serena. Serena Thompson, which I have introduced earlier. Serena, I'd like to ask you, you have heard Gabriel and Fitz-Ann share their patient experiences. You might, I think you mentioned before that it's been about 20-something years since you've used the UHN services. I want to find out from you where you currently receive care. Do you have a different experience than what Gabriel and Fitz-Ann have shared? Would you be able to enlighten us on the kind of treatment you have received over the years where you have been going for your sickle cell treatment?
Yes, thank you, Lanry. Hi, everyone. Good afternoon. Thank you for joining us. This is a very important day to me as well as to everyone else. You know, we finally get to say something. We finally get to express what, you know, our experiences have been like in a safe setting, and I appreciate that very much. Yes, I used to go to TGH a lot because, sorry, far back, I used to go to Sick Kids, and then I transferred over to Toronto General Hospital, which we normally do. But at that time, I was living in Scarborough. No, I was living in Markham. And so it was a bit of a trek. It was quite far for me to go to. So my parents found Scarborough Grace. So Scarborough Grace is where I was going to all the time for the past 20-something years. So my experience was quite up and down at Scarborough Grace because it seemed like a lot of people were not knowledgeable on how to treat somebody in extreme pain coming into the ER, especially with sickle cell disease. So I noticed that it was a struggle for me to get the proper pain medication, just to be attended to at a good time. From when I arrived, I was always waiting for hours before I was seen. And then by the time I'm seen, it's too excruciating and to deal with and be treated in a way that I can, you know, be going home, say later that day or the next day. So what would happen is that I would end up being admitted for quite some time. When I was younger, I was in and out of the hospital quite often, especially while I was in high school and college. Quite stressful for me. So my experiences in the hospital, I was just in and out all the time. So I'm pretty sure, you know, they were thinking, you know, what's wrong with this one here? You know, why is she always in and out? Why does she need so much high pain medication? And so on. So once I started taking care of my, taking initiative and understanding what was happening with me, I started being an advocate for myself. So what happened, Scarborough Grace at one point finally had a doctor that came and created a protocol and individualized our care, had our care individualized, you know, in a book that was down at triage. So once we do show up, that all we have to do is mention that we're having a sickle cell crisis and we are in that book, and the orders are in there already. And once they realize that they could call, you know, they can take care of me and call the doctor at the same time to let him know what is happening, and they've done everything in the order set, then by the time he came to visit me, I was much better and I was ready to go home. And so it's a big difference. It's quite a big difference. But I have had struggles. Now I am going to Centenary. I've tried Scarborough General. They need a little bit more of a push in initiating the protocol. But Centenary, I actually found lately that they do kind of recognize when a patient comes through ER that they're desperate and need the help. I have been seen. I do remember one time being seen less than 30 minutes, and that shocked me. So it's a shock to me when people actually know what they're doing. It's a shock when they recognize, even from the sounds I will make, because I don't cry. I'll just, you know, have tears running down my face. But they'll understand, some of them understood even just the sounds and stuff like that that's coming from us, that, oh, this person's having a sickle cell crisis. Sounds like someone's having a crisis. I was shocked. And, you know, she took care of me. I had to tell my advocate, which was my dad at the time. I said, okay, Dad, I'm good. I'm already feeling better that someone is recognizing what's happening and what needs to be done. And she put me in the bed right away and started the IV and the medication and so on. So I see, and then there's times when there is a doctor, you know, the doctor will suggest to give me half of the medication that I suggested that works for me, and then want to increase to see if it works, when I had to suggest that let's start at the maximum dose that I know works for me, and let's go down from there. And then that way my pain is subsiding, my pain is going away. We're dealing with the pain right away. The whole issue is that it's the pain that we're dealing with here. That's the first and foremost thing that we just want relief from. So when we notice that people are recognizing this, it's amazing. And you just start feeling better. The anxiety level goes down tremendously, which is part of what is a deadly cycle, really, of, you know, with the pain, and then you have anxiety, and then you're worried. Is this doctor going to understand what's happening? Are they going to respond? Is the nurse, you know, able to just poke me that one time, you know, and do they understand that when our joints are in pain, they cannot use certain tools, like say the blood pressure machine and stuff like that, when you're having extreme pain in that area. And certain little things like that, when they recognize things like that, it helps. It helps. So yes, so for me, because I'm in Scarborough, I stick to the emergency rooms that are available in Scarborough, and TGH. And the only reason why I think I wasn't going down to TGH when I was older, when I was able to travel on my own and so forth, is because of the stories I would hear from my peers and colleagues. It sounded quite scary. I've seen it myself. I've helped others. I've had to advocate for others. And when I bring them down, or we see what's happening in the, it's especially at triage, because that's your front line. That's your front line right there. And once you see what's happening in triage, then we're going to automatically assume, oh, then it's not going to work out too well going forward.
Thank you. Yes.
Yes. So that is a bit of my experience.
Thank you, Serena. And I know you have so much to say.
I know. We're on a time crunch.
Well, honestly, I want to keep listening too. I'm just mindful of the time. It's for me, from what you're sharing, it's not much better anywhere, anyways. But one thing you say that struck me that I think is important is creating that individualized protocol, or some sort of, because I know even in the education system, we have what we call the IEP, whereby when somebody needs that individualized, plan, they get that. So if there is individualized plan to help the sickle cell patient when they show up in the ED, I think that's amazing. I love that when you mentioned that.
To me, if anything, it saved my life.
Yeah, I think it's a great thing.
That's how I feel.
Yes. Quickly, I know we have so many questions that are showing up, and I want me to make sure we get to most of them, but we need to hear quickly from Dr. Pendergrast. As an hematologist, Dr. Pendergrast, how do you think the red blood cell disorder clinic could improve patients' experience at the emergency department as an inpatient, and even in any department within the hospital? How can we improve the experiences of sickle cell patients at UHN? Dr. Jacob Pendergrast.
Thank you, Landry, and Serena, and all the other panelists for contributing to this discussion. I've been sort of reflecting a bit on the issue that's facing us here, and how to go about addressing it. And I think there are sort of three questions we have to consider here. The first is, what is it that we are trying to do? Next question then is, what's the best way to accomplish that? And then the third question is, how well are we doing in that approach that we're taking? And I think you really have to consider each one of those three questions before you sort of jump right to, let's just try this as the new fix. Not to say that the new fix, the idea is a bad idea. It may actually turn out to be exactly what we need to do. But I think we need to sort of back up a little bit. And so the first question about what is it that we're trying to do here? I think one of the things I think that is difficult for many healthcare workers working in the emergency room is it's not entirely clear what it is that they're being asked to do, because very often they feel they don't have any backup from the hematologists in the hospital. So the sickle patient will present, and that sickle cell patient may have very little care being provided to them in their life generally. They may not be having medications prescribed. They may not be having surveillance for complications. They may not be getting social work support. They may have nothing. In fact, very often the patients come in just in pain, and there's nothing for them, in terms of the care being provided. And that puts a lot of pressure on the emergency room to say, okay, well, how much of this can I fix in this one visit? And if you are meeting a patient for the first time and you're sort of wondering like, God, okay, I think, some of this is a vaso-occlusive pain crisis. Some of it is because you've got avascular necrosis and your hip is shot. Some of it is because I think you've got a chronic pain disorder, you know, from, you know, years of undertreated acute pain. That's, you know, it's asking quite a lot. And I think that's where often a lot of this inconsistent care comes from, because it's so enormous, you know, the catching up that you need to do. If, on the other hand, you are working in a hospital or are part of a system where you know that there is a comprehensive care program that is out there to kind of take care of the long-term issues, the sort of like the you know, the issues about how are you doing with your medications, you know, like in terms of hydroxyurea, you know, how are the transfusions being administered? Has someone checked to see if you have asthma? How are, you know, what are your living situations like? You know, if you know that somebody out there or a program out there is available to take care of those things on a long-term basis, then you're freed up in the emergency room to focus on the issue at hand, which is that you have a patient here who is in pain. And what you need to do at this point is make sure that there's nothing life-threatening going on that's causing that pain, you know, so that you can, you know, because that's not all pain is the same, right? I mean, there's, I think, you know, some of it is, you know, typical pain crisis. Some of it is actually like, you know, life-threatening things like multi-organ failure system or fat embolism or acute chest syndrome. But, you know, you can sort of deal with the emergency issue. And then all of that long-term stuff, all of that sort of outpatient management, you can then refer the patients to the Red Cell Disorders Program and say, you know, your patient was in here, they had a pain crisis, we took care of it, and they went home. I'm concerned about this patient. You know, they're in here a lot. They clearly have no support at all. I really want to get them into your program. And at this point, we can say, we've got it, and we'll get them in, and we can provide that sort of comprehensive long-term care, which, if you're doing it well, one of the ways that you know you're doing it well is that patients aren't in the emergency room having pain crises all that often. The problem is that, you know, if you'll pan back out and look at sort of the big picture here, I mean, the statistics, every time I review these, it just blows my mind. The average life expectancy of a patient with sickle cell disease in North America in 1970 was 17 years old, right? This was a pediatric condition. Now it's different. Now it's up to maybe 60 years old and getting better all the time. So there's this big population of adult sickle cell patients out there. But the healthcare system still has not caught up with this fact. And so there are still so few adult comprehensive care programs out there. And so this is why, you know, you go from a pediatric hospital where the emergency departments and the sickle cell programs are working very closely with each other and coordinating. And, you know, you go to the adult hospital and there's nothing. It's just the emergency department. That's it. You know, maybe you'll find the odd hematologist who's got an interest in this, but, you know, they're treating 10,000 other hematology conditions and they're kind of squeezing in the sickle cell where they can. It's just not good enough. And so if you can provide that kind of comprehensive, long-term, lifelong care, where you're really sort of trying to like anticipate problems and treat them and deal with the long-term issues on a longitudinal basis, that makes it much more straightforward for the eMERGE to, you know, to focus on what they are positioned to do best, which is deal with the acute issue. And they don't have to get into the, you know, any kind of concern about, I'm worried about this patient's developed tolerance. You know, they're requiring doses of narcotic that I haven't, you know, prescribed frequently. Like, you know, all of that sort of long-term stuff can be referred to our program if we can work together. So I think that's really, I think, the main benefit of having a comprehensive care program. It just allows everyone to know what their particular job at what particular point is. I would say conversely as well, right? I mean, if you have a really good, care map with the emergency room, then you won't have patients coming into a clinic appointment in an acute pain crisis because they don't trust the eMERGE. Like, this occasionally happens as well. They'll come to a clinic and they're like writhing in agony, and it's like, I'm not equipped here to take care of this. You need to go to the eMERGE. And it's like, I don't want to go to the eMERGE. I've had a bad experience there. Can't you take care of me here in clinic? Again, that's not ideal either, right? So I think as long as everyone knows what they're best positions to do, then you can do that well. And so then you get to your second issue about, okay, well, what is our goal of treatment here? And then you can figure out, okay, what's the best way to do that? So I think, if the eMERGE is clear on what their responsibilities are and what they can hand off to the outpatient clinic, then they can decide, okay, what's the best way to treat an acute pain crisis? And it may be that having personalized care plans for each individual patient is the way to go. I think, there are some hospitals out there that have success with that. There are some drawbacks in that approach as well, right? Because there are a lot of patients out there who don't have that kind of personalized care plan in place. They're new patients. I mean, we have like between 40 and 50 patients born with sickle cell disease every year in Ontario. And so they show up and some of them are just going to need to have good care provided to them the first time they visit, right? They're not going to have a care plan waiting for them. And also you might develop a care plan as an individual patient, and then that care plan needs to change. And then there's this whole process of getting it updated. So I'm not saying that's not the good solution, but I'm just saying another solution would be to have a nimble, adaptable, flexible a protocol that you can use for every sickle cell patient that has a little bit of, configurability as you're applying it to your patient. And that's kind of the approach that we've tried to take at the Toronto General, where we have like a standardized order set that is supposed to be applicable to every single sickle patient. It can be tweaked, there are little check boxes, do this or this, you can provide a drug in this range to that range, order transfusion if the following, that kind of thing. That's a good approach as well. The third issue though, and I think this is the most important thing, is whatever it is that you've decided that is the best way to do what you're trying to do. And if in the eMERGE, it's treating a pain crisis. Whatever it is that you've decided is the best way to accomplish that, you do have to go back and check and say, how are we doing? Like, are we actually, we have this process map, we've got it all like this, then this, and this, and this, and this person, and you get it all figured out. Every now and then to go back and look and say, are we actually doing this? Is it actually happening? We have these pre-printed order sets, at the Toronto General Hospital. I'll be totally honest, we don't check all that often to see how well we're using them. We'll occasionally see a patient come into the emergency department and you'll sort of flip through and look at the orders that are written. It's like, hey, where's the pre-printed order set? Nobody used it. Or if they did use it, they started filling it out 4 hours after the patient showed up. And so that's what that last step is, that third part of how well are we actually accomplishing what we think we're doing. That's called quality assurance. And again, this is something that the medical system is relatively new to. That's sort of check, just check how you're doing. All of us need to do this. I need to do this in my own practice. We have to look back and say, this is what I think is the best way to do it, but am I actually getting there? So I actually think that that's probably the first thing that we really need to work on here, is say, we know we have a standard, we all agree, that best practice is that if you have a sickle patient who has a pain crisis who comes into the hospital, they should be getting that pain treated, start treatment within 30 minutes. I'd be really interested to know how often we're hitting that target. I'm betting you it's not that often. And then the next question would be, why? What are the barriers to doing that? And you really need to understand what the barriers are before you say, I'm just going to write a new pre-printed order set. It's like, well, if the old pre-printed order set is sitting in a cupboard somewhere, writing a brand new one is not necessarily going to fix the problem. So you really got to spend that time drilling down and finding out where the barriers are. But I think getting back to the main thing here is that, and this is a question that was put to me about what working in the red cell disorders program is for. I think what this does to support the eMERGE is to say, look, you do not have to fix everything in this person's life, okay? They're in here with an acute pain presentation, treat it. And all that other stuff that you see and that you're worried about, all the social stuff, all the other sort of long-term medical complications, all that, we'll take care of that. Just make sure that they get an appointment to see us after you've taken care of their pain, and we'll take care of that. So I think that's the main thing, is just to have that partnership.
Thank you, Dr. Pendergast. I really appreciate that response. It was very comprehensive and very helpful. I just want to say to everyone to please bear with us because we give about 3 minutes before we start. We may need to take that 3 minutes back from you and finish around 12:35 because we have so many questions here. And I'm going to ask our panelists, please take 1 minute or so to answer each question because we have so many to cover. So I'm going to start with the questions, and any one of the panelists can please take the question. This one is posed to the team at UHN. Is the Sickle Cell Working Group at UHN taking steps to develop an integrated care pathway? Dr. Brian or Dr. Hassan?
Sure, so I can speak to that. So the existing care plans in the emergency department, so the order sets that we've been talking about have been in place for some time now. Like Dr. Pendergast mentioned, they're in the process of being revised now, but we know that that's not the end all be all. It's fantastic to have a perfectly written order set with a great plan, but if no one uses it, then it doesn't help, right? So what we are hoping to do is to increase or improve how seamless the transition is from the emerge to the inpatient world, because that transition has been quite difficult for a number of people as well. And we're looking at exactly some of the things that we've been talking about already. So Jacob, I was smiling when you were talking about how often are we making that 30-minute target? Because anecdotally, we know that that's incredibly rare that we meet the 30-minute target, right? But in order to really make change within our hospital, we need some numbers to back that up. So part of what we're working on in our working group is exactly what you were talking about, which is a quality improvement initiative. And so we're wanting to get some of those numbers together. So in particular, looking at how quickly we're getting people pain medications. Just like has been mentioned previously already, we know that the earlier people get management of their pain, the better they're going to do. So the less likely that they are to need admission to the hospital, the shorter the duration of their pain. So lots of good reasons to focus on that as a starting point, and consistent with what's recommended in the clinical handbook that we use as a guide. We're looking at that 30-minute target. And so that's one of the quality improvement steps that we're taking to try to figure out where we are. We're really doing this as a multi-pronged approach. So we are revising the order sets just to make sure that they are up to date and consistent with what we want to be doing for care. But then we're looking at how well are we applying them in the emergency department.
Thank you, Dr. Brian. Next question. How can we be effectively supportive when our friends are going through a crisis? What can we do to ensure that the crisis doesn't get worse than it needs to be? Any of our panelists can take this. Thank you.
I can take that. So really, like when we're having a crisis, there's as a friend, there's nothing really you can do. But I know for myself, and I feel like I can speak to others with sickle cell, that we really appreciate the presence and just moral and mental support of our friends, and just that enough. That alone is enough, like, to help us, like, mentally get through these situations.
Thank you, Gabriel. Next question. What are some of the ways that you feel unconscious biases or prejudice shows itself in the care of patients with sickle cell disease? So I'd like, again, one of the ED doctors or Dr. Pendergast to take this question about unconscious bias and prejudice that shows itself in the care of sickle cell patients.
So this is something that we've been talking an awful lot about. It's when we look at the differences on the larger scale of funding for sickle cell, for example, and Landry, this is something that you and I have spoken about. When you think of sickle cell, while we know it affects people of all races, in Canada, most of the patients who are affected are Black. And so a lot of people think of sickle cell as a Black disease. When you compare the kind of funding and research support that there is for sickle cell to other maybe similar genetic diseases that are considered more common in the white population, like cystic fibrosis, there are significant differences there. And so those are things that we see on the larger scale. On the individual scale, and I'm sure that that Fitz-Ann and Gabriel and Serena can speak to this, but I think the experience of feeling like you need to be dressed up to go to the emergency department, feeling like you need to speak a certain way in order to be believed in the emergency department, underlying that is stigma and racism, right? If you come to the emergency department and you tell us that you are having 10 out of 10 pain, that should be the end of it. It shouldn't matter how you're dressed. It shouldn't matter how you're speaking. It shouldn't matter how you look. It should matter that you've got pain and that we need to help you, right? So I've certainly heard from patients that that they do feel very much judged, and that this is another barrier to coming to the emergency department and another thing that makes them feel unsafe coming in. But this is certainly not something that I should be speaking any more to, and I would defer to Serena and Gabriel and Fitz-Ann.
I want to thank you, Dr. Brian, for this. And to build up on that question, the next question is, how do you see implicit biases and blatant racism? And I think you kind of answered that question. It is, how do you see that impacting care? We see that it impact funding, it impacts care, impacts knowledge. And it's something that we are working on in terms of advocacy as well to fix. Because again, as you said, it does not only affect Blacks, yes, predominantly Blacks, but it also affects other people. If you think about it, in India, about 1.8 million people in India have sickle cell disease. So again, we need to start to look at sickle cell is a global issue, and we need to apply this beyond the boundaries of Ontario or Canada. I'm going to go quickly into the next question. So Dr. Caroline Rowley from Kenya Wellness Center in California is with us today. She's mentioning that in California and other states in the US, they have infusion centers or day treatment hospitals, which tends to be better than patients frequenting the ER, and wanted to know if this is available at UHN. I know that UHN did a pilot, something around that with the Women's Hospital. I would like Dr. Pendergrass to answer that question. Thank you.
Yeah, this is something that there's lots of evidence in support of this day hospital model. You know, it results in, it takes, you know, pressure off the emerge. It results in fewer admissions, so it takes pressure off the inpatient units. You know, it's better for the patients themselves. There's a lot of data out there. It doesn't really require more study, to my mind. There have been multiple publications on this. And we did actually pursue this and are still asking about this at the University Health Network. It's just, we haven't, it's never, I'm trying not to say too much here. The thing about working in a large hospital is you very rarely are told straight out no to anything, is my experience. No one ever says, no, you can't do that. It's more sort of like, well, it's an interesting idea and you got to run it by this person. And like, you know, you should talk to this person. And there's this committee, which then no longer exists. And you can kind of spin your wheels for quite a while doing this. This is not an excuse to say that, you know, we can't have done better. We do need to have this. And we've had, you know, pilot day hospital programs set up at other nearby centers like Women's College Hospital. You know, I think it's something that you just have to just keep knocking and knocking and knocking at the door. And you know, there's a lot that goes into making a system like that work. You know, it's not just, you don't just flick a switch. You have to, you know, one of the biggest challenges in a hospital is actually physical space to do these things. The hospitals are tight in terms of just available rooms, that kind of thing. Then you have to get the staff, then you have to get the supplies and all that kind of stuff. It can be done for sure, but it requires fairly focused and prolonged pressure. And then you have to, really, like you might get sort of approval to do it as a pilot, then you have to make sure that by the time it gets to the end of the pilot, you've done the hard work of gathering all your data along the way to justify keeping it going. But yeah, I'm not aware, to be honest, of any hospital in Canada that has a day treatment center for sickle patients. It's, partly, I think, the reason it's, the US is further ahead in Canada on this is that there's just more patients. It's like 100,000 sickle cell patients in the United States. Canada is like maybe 5,000 or 6,000. So the political pressure is not there yet. But absolutely, I think anyone who has even looked, briefly at the data on this knows that that's the way to go.
Thank you, Dr. Pendergrass.
May I piggyback off that?
Sure, Gabriel.
I actually experienced that the short program at Women's College Hospital, and it was amazing. It was probably one of my best sickle cell crisis experiences ever. But I guess like with the pilot, there was a lot of issues with accessibility. So when I had my next sickle cell crisis and going back there was kind of hard because it was at night and you have to get approval from the doctor, blah, blah, blah. But when it was up, I did experience it and I thought it was amazing, and I feel like we should bring that back.
Thank you. One question from someone is there capacity for education training focused on anti-racism and specifically anti-Black and anti-Indigenous racism to support staff in better understanding how implicit biases can impact patient care? Any of the panelists, please.
So I can speak to that a little bit on a sort of a broader scale. So there's a lot of discussion in emergency medicine in the US and in Canada about the role of racism and colonialism and anti-Black racism specifically in emergency department care. And in emergency medicine in Canada, there's been a real call for increased training, increased incorporation in postgraduate education, so training our residents, training our medical students. One of the things that's happening in the next little while is, so we had a bit of an introduction to some key topics in that area with the Canadian Association of Emergency Physicians. They had a national grand rounds just earlier this week. They are going to be hosting a session dedicated to sickle cell in January. And this is the first time that there's been a national grand rounds for emergency physicians dedicated to sickle cell. And that will be an opportunity to speak to some of these issues as well. The focus of that session is going to be sickle cell in the emergency department, what our patients want us to know. And so that's going to be additional training for emergency physicians. I'm leading a group of emergency physicians across the country that are trying to tackle issues around racism and colonialism, and putting together specific recommendations, not only for emergency department and patient care, but also for medical education and for physician advancement as well. So we recognize that barriers due to stigma and racism and colonialism not only affect our patients, but are barriers to physicians who are Black, Indigenous, and people of color entering into emergency medicine. And I think some of the things that that we've heard today speak to the importance of having healthcare providers who have a variety of lived experience, and so who can bring different perspectives and try to get past the history and unfortunately present of racism and colonialism in emergency medicine.
Thank you so much. We'll take 2 more questions and we call it a day. This comes from one of the attendees who mentioned that they're new to the forum and the organization, and after the experience of lack of information that was available for individuals with sickle cell traits, their hope is helping in any research directed to ensuring the right tests are available to inform individuals with traits to help make informed decisions in respect to childbearing, choosing a partner, and so on. How does someone get involved in any fundraising event to help such initiative if it exists? If not, what has been done in this area? Quickly, I can respond to that to say in Ontario, we have the Sickle Cell Association of Ontario and the Sickle Cell Awareness Group of Ontario that works on educating and raising awareness around sickle cell trait and so on and so forth. As we know, if you have the HOIP card, everyone in this province can definitely go to their family doctor and ask for sickle cell specific test, hemoglobin electrophoresis testing, they call it. And for the sake of time, I would say if you need more information, please connect with Sickle Cell Association of Ontario and Sickle Cell Awareness Group of Ontario, and we'll be able to give you more information when it comes to sickle cell traits and the research work, awareness programs that we do have to support this in our province. Thank you for that question. Last question, but before the question, I want to comment Jane Ballantyne. I think she put a lot of great comments in there about the patient relations. And on that note, I want to say that one thing that even as a patient advocacy group, SCD has learned that many of the sickle cell patients, even when we have the not so pleasant experience in the hospital, when we get discharged and we go home, that's it. We don't report on our experiences to the patient relations. And we can understand it could be based on fear of retribution. What happens if I report? Will I get tagged? And next time I go to the hospital, what will happen? There are many reasons why that's not happening. But we are using this session to also empower and to say, no retribution will come your way. But what is going to happen is going to help get the patient relations to have data to say, this is the number of patients with sickle cell who are reporting suboptimal care. The hospital need to do something. Right now, they don't have data on sickle cell because we are not reporting. So let's report, let's let them know when you have great experience, talk about it too. Let them know they're doing well. It's very important. So on that note, I put that in the chat. If we didn't get to your question today, we apologize. But I've asked you to kindly send me your questions at sicklecellawarenessontario@gmail.com. We'll get your question to the right people and we will send the response to you. We want to thank every one of you for joining us, for being part of this session. And Dr. Hassan Sheikh, we didn't hear you, but in 1 minute, I would like you to just tell us about, as a doctor who is also very in tune with addiction. Dr. Brian mentioned that only 2% of who we think are addicted are actually addicted to opioid type of medication when it comes to sickle cell. Dr. Hassan, can you say just in 1 minute, what do you think about that? Then we'll close this session off. Thank you.
Good thing, thanks, Landry. Yeah, just very quickly. So I also practice addiction medicine as an outpatient. We were chatting about this in one of our pre-meetings, just that, the rates of substance use disorder is quite low in the sickle cell population. As far as I can see from the literature, no higher than the average person. And there is, sometimes this feeling that people are drug seeking, but really what that is undertreated pain. And the longer that we leave undertreated pain, the harder it is to treat it, the worse the outcomes are. And especially in the emergency room, we need to treat that pain aggressively and respond to patients because we're really not creating substance use disorders in the emergency room by giving people the pain medications that they need. And really the driver of this overdose crisis is illicit fentanyl use, and not really concerns about properly and adequately treating pain in a monitored setting like the emergency department. So I just encourage everyone in those settings to be, very patient-centered in their approach to treating pain.
Thank you. And on that note, we thank every panelist and presenters, our great guests, and the UHN team, including the Sickle Cell Disease Working Group, Patient Relations, Inpatient Hematology, the SCD team, and the SCAHO, and everyone who has joined us today. And we ask you to please have a safe weekend, and we'll see you at our next session again. Thank you, everyone.
Thank you.
Thank you.